surrogate marker, because with all those circulating biomarker, and stage intermediate criteria, and intermediate endpoint, etc. But a surrogate marker, this is something different. A surrogate marker means that the reduction of the biomarker should translate into less cardiovascular events. And it has been very well recommended by the American Association here in this scientific statement that you should complete at least 6 steps in order to demonstrate that your biomarker test is a surrogate marker. And I will go very quickly into those various steps. The first step, this is a proof of concept. And the question is, do novel marker levels differ between subjects with and without outcome? Of course, many papers, cross-sectional studies, arterial stiffness is increased in hypertension, diabetes, chronic kidney disease, chronic heart disease, etc., etc. So it is well accepted. Prospective validation, it's a little bit different. It's more difficult. You need a longer study, longitudinal study of several years. And here, I'm happy to show you this old paper, more than 10 years ago, in which we showed in 2000, roughly, that arterial stiffness was a predictor of total mortality. The highest, the pulsar velocity, the lowest, the chance of survival. And now, 10 or more years later, we have 17 studies for carotid femoral pulsar velocity. This is a meta-analysis published by Karl-Ambros Vlachopoulos. You see here that the various studies entered into this meta-analysis, and here the risk ratio, 1.5, roughly, for all criteria, total cardiovascular events, cardiovascular mortality, all-cause mortality, for one standard deviation, which is quite good enough and interesting. And furthermore, we published this year in JACC with Jörn Lenschow in Cardiff, a meta-analysis in individual data on 16,000 subjects. And you see here the major finding, which is interaction with age. The younger the patients, the larger the predictive value of carotid femoral pulsar velocity. This is important because if you want to do preventive cardiovascular medicine, you have rather to target younger patients in whom you can organize cardiovascular prevention algorithm rather than in elderly patients where it may be too late. So the predictive value of aortic stiffness has been demonstrated. Now it's well established for various outcomes. You have total mortality, cardiovascular mortality, coronary event, asymptomatic coronary artery disease, stroke, etc. And the various population, general population, elderly, hypertensive, diabetics, etc. So it is well accepted. And now there are 2 steps to be completed. This one is extremely important. I have no time to detail. This is incremental value. What does it mean? It means that if you measure pulsar velocity, you have an added value in addition to the European score, or the Framingham score, or any risk score. And it has been well demonstrated. And the second one, which is clinical utility, it is more for a certain type of individuals. It is named reclassification. Reclassification means that when you consider patients at intermediate risk, these are the tricky patients. They are not that high, not that low, we do not know what to do. To measure pulsar velocity, you can reclassify 20% of them into a high risk if you measure pulsar velocity. So clearly, this is very useful. And I will finish with number 5, which is clinical outcome. The true study needed to show that a reduction in arterial stiffness translates to a reduction in cardiovascular event. And if you follow the recommendation of the American Heart Association, finally, this is just a question of clinical trials. So you have a study sample, you randomize patients. In one group, you measure biomarker, you tailor your intervention to the biomarker level, and you measure health outcome. In the other group, you do not measure biomarker, you only apply the guidelines, the standard intervention, and you measure health outcome, and you compare. And this is exactly what we are doing in the SPART study, a study which has been launched in France, thanks to the French Ministry of Health and the French Foundation for Research in Hypertension. We intend to include 3,000 patients for 4 years in the full design in 40 investigation centers. And the inclusion criteria are medium to high.